it's about an hour. Is that the plan?
Yes.
Yes,
So,
yes, that's the
Okay,
plan.
great. Great.
So,
So let me.
just I'll introduce you first, then I will start.
Oh, sure.
So, welcome everyone. Today we are privileged to have Professor Mahroo with us to talk on inherited retinal disease cases and phenotypic features which can aid in genetic diagnosis. So, Professor Mahroo doesn't need any introduction. He holds severe, very important features, important positions in more fields. He is a professor of retinal neuroscience at University College of London. He is consultant ophthalmologist at Moorfields Eye Hospital, London. He is honorary consultant at St. Thomas Hospital, London. He is research affiliate in Department of Ophthalmology, Development and Neuroscience at University of Cambridge. He is the director of standards and board member of ISCEV, which is the international body to monitor all the electrophysiological tests. He is abstract editing committee member for ISCAV. He has more than 165 publications and he is a well-renowned specialist on inherited retinal disease. So he has got multiple prizes, including Michael Sanders Award Lecture, Institute Award for Teaching Excellence, Award for Public and Patient Involvement and Engagement, Rising Star of the Year, and he has received grant awards of more than 2 million pounds. So we are lucky to have Parveen Sen ma'am with us. Ma'am is a senior consultant and head of retina services at Dr. Agarwal's Eye Hospital, Chandigarh. Her area of interest are complex vitreoretinal surgeries, ARMD, retinal imaging, and inherited retinal diseases. Madam has published more than 113 peer-reviewed publications and many books. Sir, ma'am has made several national and international talks. She has trained many of the Indian and international ophthalmologists. She has received multiple awards, including 2022 Honor Award by AIOS for maximum peer reviews for IGO, Best Original Paper published by Delhi Retina Forum, and Best IGO Paper published in Retina. Welcome, ma'am. We have with us Dr. Vinod Kumar, sir, who has been my teacher. Sir is an additional professor at Vitreoretinal Services in Dr. RP Center, AIMS. Sir completed from GNEC MMC and senior residency from the same institute. Sir has been teacher to many of us. Sir has authored many books, including Handbook of Clinical Trials in Ophthalmology. Sir was the editor of Daily Journal of Ophthalmology, in which time Daily Journal of Ophthalmology had flourished much. And Sir has got many awards, including the V.K. Kallar Memorial Trophy by Delhi Ophthalmology Society. Thank you, sir, for joining us. We have Dr. Poorna Chandra, who is a vitreoretinal consultant at Narayan Nethralaya, Bangalore. He has completed postgraduate from Armed Forces Medical College, and he has done long-term fellowship in vitreoretinal surgery from Narayan Nethralaya. His interests include inherited retinal diseases. Dr. Poorna has published many peer-reviewed articles, and he has won multiple awards, including Professor S. Natarajan Award for Best Paper in Vitreoretinal Diseases. We have with us Dr. Mayank Bansal, who is a consultant in vitreoretina and cataract in Delhi. He is attached to Claritas Eye and Retina Institute, Max Healthcare, and Fortis Hospital. He was awarded the Dalai Lama Award and Prem Prakash Trophy at AIMS New Delhi, and he was conferred the member MRCS Edinburgh. His current interest include gene editing. We are privileged to have Dr. Simar Rajan Singh with us. Dr. Simar is an assistant professor in vitreoretinal surgery at PGIMR Chandigarh. So he did MS in ophthalmology from the same institute. He was awarded the NIH award by the National Eye Institute USA, and he has won multiple awards, including E.T. Selvam Award and Hanumant Reddy Award AIOS. So thank you all for joining us. We'll go directly to the presentation of Professor Mahroo. Thank you. Professor Mahroo.
Great. Thank you very much. So I'll just share my slides. Last time we had some issues, but hopefully this time it'll work without complication. I did a Zoom update, so hopefully that'll help. Okay, you can see that okay?
Yes, yes. Thank you.
Okay, brilliant. So thank you very much for inviting me back. It's always an honor, and I learn from these discussions as well. And this time we'll be focusing mainly on cases. We'll try to make it interactive. I don't know, that doesn't always work online, but if you're welcome to say things or suggest diagnoses as we go along. You can even put things in the chat. I may not always be able to see it, but Dr. Koushik, if you want to, read out if anyone says anything, feel free as we go along. Before we go on, I just want to advertise that I'm organizing this webinar that'll be next week on Wednesday, so literally a week today, 9 to 10:30 Eastern time. So I think that's 2 p.m. UK time. So I think it'll be 7:30 p.m. India time. It's free for Arvo members and it's $15 for non-members. But there'll be it's about global research, setting up research in a new country. There'll be a bit about research in India as well. So do have a look, and if you're interested, do register. I'll just acknowledge the clinical genetics team at Moorfields, some other colleagues from other places around the world who help us a lot with our genetics cases, and our funders. And I'm going to recap just for a couple of minutes some things that we mentioned last time that will be important to keep in mind, because the main theme today is trying to what features guide you to what the likely genetic causes of your patient's IRD. As we know, 280, 300 genes are possible, and sometimes you can't really distinguish from the phenotype. You can't get it down to a single gene, but maybe a handful of genes, and that can be important in trying to get the right genetic diagnosis. So, as I said last time, we suspect an IRD if we have something bilateral, symmetric, especially if it's a young patient, not always young, or there's a family history, but always consider the other differentials. Drug toxicity can look very much like an inherited retinal disease. Sometimes inflammation can look more symmetric than you're expecting. So these things are possible. Having an idea of the history. Sometimes we get less good at taking histories. We just concentrate on the imaging or the electrophysiology, and we forget that there's a whole history. And sometimes the end result looks very similar for many different IRDs, but when you something gets called RP, but when you ask the patient, it's clear that their central vision went first many years ago, and actually it's ABCA4. It's not RP, for example. So having the history is important. A family history is important. Examining relatives where appropriate and where easy, especially for some X-linked retinopathies. You may see a carrier phenotype in mum, and that will really tell you what the diagnosis is likely to be. And
Retinal.
Is it Dr. Omar?
and I think maybe someone needs to mute. And also considering syndromic associations, so taking a medical history, because there are certain things that, Usher syndrome, that's been in the literature for a long time, but even relatively newer associations, we're finding certain genetic causes are associated with loss of sense of smell, for example, and that could pinpoint the possible genes. Also, when you get the genetic diagnosis, you may then know what other organ systems need to be looked at. Imaging, we'll talk a lot about imaging today, the features on imaging that might point to particular genetic diagnoses. Electrophysiology, we may not say much about that today, even though it's my passion, but sometimes that can really point to which gene or a handful of genes. Genetic testing, depending, now in the UK, we're doing whole genome sequencing on almost everyone, but it could be different in different settings. And then all of the supportive stuff that we shouldn't forget about, the potentially treatable complications and the novel treatments that we discuss with our patients, although there is really no approved treatment apart from Luxturna for RP65, which is very rare, but at least being aware of what's out there can be helpful in reassuring patients that research is ongoing, and we hope there'll be more treatments in the future. This is just one example that was relatively recent. Actually, it's a few years ago now, but CNGB1 is a gene that's associated with RP. And often these patients have RP. It could be mild, could be severe, but usually they have congenital night blindness because CNGB1 encodes the beta subunit of the rod cation channel. So the rods aren't working from the start. So even before they've died, the rods aren't working. So what distinguishes some of the phototransduction genes from other causes of RP is that they have very early onset night blindness. And then the other thing is that some of these patients, not all of them, maybe a third of them, have problems with sense of smell. So just a few months ago, I saw a patient in clinic where they had RP and they had some variants of uncertain significance in CNGB1, and the genetic testing was done even before. You might want to mute the audience
Yes,
if you can. If your patient's got a variant of uncertain significance, as this patient had in CNGB1, but when I talked to the patient, the night blindness was there right from the start, and I said, "What's your sense of smell like?" He says, I can't smell anything. My wife says this thing you've got is just for show. It doesn't work at all, this nose of yours." And so that told me that no doubt that the CNGB1 variants of uncertain significance they found were the cause in him. So we were able to, be sure of his genetic diagnosis. And he was very, for some reason, reassured to work out that the same thing that was causing his eye problem was causing his problem with his sense of smell. It wasn't just he was silly or something, or his wife would make fun of him because he couldn't smell anything. It's the same genetic problem because it's expressed in olfactory receptors. Another good resource is Stone rounds. So Ed Stone is an inherited retinal disease specialist in Iowa, and he does these fortnightly rounds. And he was doing them at a time that was quite difficult for the UK and India because of the time zones. It was Iowa time, but he is doing other sessions like tomorrow at 3 p.m. UK time, which will be, I think, 8:30 p.m. or something your time, maybe on around then. He's doing a live session, so I would go to this website, and he's very good at teaching. He doesn't speak super fast like I do, so you can learn a lot from those online rounds. And also when you go to the website, there are clinic simulators, and you can just learn and look at patient images and try and guess what the gene is. And that's their eye disease form. Why get a genetic diagnosis? Because people often say this very academic, why you can't do anything anyway. As we've said before, you get a better understanding of the disease. Patients often want to know, okay, you can't do anything for me, but what's the risk of my children being affected? And until we get the genetic diagnosis, it's not easy to be sure about the risk to children. And there are some gene-directed therapies, trials going on that you need to know the genetic diagnosis, need to be secure about that before the patient can be enrolled, and also understanding systemic implications. So as I mentioned, I had a patient where just from the eye, I could tell they had something that was going to affect the heart, and it made the cardiologist give him the right treatment rather than the wrong treatment, and now he's still alive and doing very well, just from his OCT findings. So sometimes getting the right genetic diagnosis because of some specific eye phenotype can help them systemically. And then the other reasons that are helpful are that you can exclude a non-genetic etiology. Just today, I was discussing with a patient who was having immunosuppression for a presumed inflammatory retinopathy. We did genetic testing. Actually, it's a genetic retinopathy. And unfortunately, there's no treatment, but at least all this immunosuppression that could give her toxic side effects, she didn't need to have. So you can help your patients in that way. And also sometimes patients have mixed disease, something genetic, something inflammatory. At least we can work out what the genetic bit is when we get the positive genetic diagnosis. So okay, don't worry about that. And then the other bit might be something else. And as I said last time, our old way was you take the history, you think of the likely genes, you sequence a specific gene, you get the answer, or you get a negative result, then you think some more. Now, in many settings, you just sequence a big panel of genes. So people think, well, why do you even need to think anymore? You just do all the genes and you get the answer. So no one needs to think, right? Obviously, that's not the case because you get lots of answers. You get lots of variants of uncertain significance in our patients, and you have to go back to the history and the phenotype and think, well, what was the gene that would be consistent with this phenotype? And then you work out which of those answers is actually the right one. Or you get negative results, and then you don't know which gene to really focus on. And again, you go back to the phenotype and you say, well, it had to be one of a few genes, so let's look at those, and then you find the answer. And then we'll have AI that might take over. Okay, so now we'll go through some cases. And one of them I mentioned last time, but I thought I'll do it as quick revision. This was a 51-year-old who was referred through her GP, and family members apparently have retinitis pigmentosa. Patient might have a dormant form. What does that mean? I don't even know. And otherwise, they had some hypermetropia. This was the family tree. So what inheritance do we think this patient has, this condition? So that's the patient. And these are the other generations, and filled in means they're affected, and open symbols means they're unaffected. So what would you say? You might remember we went through this last time. Anyone want to say what the inheritance is likely to be? Any thoughts? You can either unmute or put in the chat. So when you look at it and you see multiple generations affected, you might think this should be autosomal dominant. So that is certainly possible. But there's another thing that's possible. It could also be X-linked. Why? Because there's no father to son, direct father to son transmission. And if you don't see father to son transmission, you can't exclude a possibility of an X-linked disorder. Because although X-linked disorders usually affect males, there are some that can affect males and females, although usually the females are much more mildly affected than the males. So that's exactly what we said. The fellow said, I think it's dominant. I said, yes. What else could it be? Could also be X-linked. Then we looked at the phenotype, and this is a typical carrier phenotype in what condition? Any thoughts? Anyone want to suggest this kind of... Yeah, exactly right. Choroideremia, and the autofluorescence, often you see it more than on the color. And then you look at the OCT, there's actually not much degeneration. It's all at the level of the RPE. And exactly right. That's the typical carrier phenotype for choroideremia. So, and actually the males in her family were already known to our service, and they indeed did have mutations in the choroideremia gene. And that's what it looks like in a male, much more severe. So it's good to have some familiarity with these carrier phenotypes. So choroideremia has that carrier phenotype. Ocular albinism, which is an X-linked disease, has a carrier phenotype as well. The females have no symptoms, but they have particular appearance of their fundus. X-linked RP, the females are either not affected at all or might be mildly affected, but they have a carrier phenotype, a tapetal reflex. X-linked retinoschisis, there's no carrier phenotype. But these other things there are, and there are gene therapy trials for X-linked RP. So it's helpful to be able to get the right genetic diagnosis. That's the carrier phenotype in ocular albinism. They have these hyper and hypopigmented that you often see on autofluorescence as well. Streaks, they call it the mud-splattered fundus. This is the carrier phenotype in someone with X-linked RP. So they have this so-called tapetal reflex, this kind of weird radial shine that you sometimes see it better on autofluorescence, then you know that this patient is a carrier for X-linked RP. So say you're seeing the son of this patient and you have mum there, you can look at her and say, okay, right, that's what it is. Most likely gene RPGR, and there are some other X-linked RP genes as well that you might consider RP2, but RPGR be the most likely one. And we've got this big review we published a few years ago on X-linked retinopathies, 44 pages. And I produced this algorithm at the end that I always feel no one will ever use because it looks complicated. It's not that complicated. If you have a male with a non-syndromic retinopathy and an X-linked pedigree, so you're sure you look at the pedigree, so that is definitely X-linked, like, maternal male cousin affected or maternal uncle affected or something like that, you think this is X-linked, then you just go through this little algorithm, either it's electrophysiology, something on imaging, and you get it down to one gene or a couple of genes. So it's quite powerful. And we've had patients who've been negative with whole genome sequencing, but you go through the algorithm, you say, oh, it has to be this one gene. So let's look at it properly, and we find, oh yeah, they missed a mutation there. So we now go on to, let's see. Sorry, it's not moving yet now. Case 2. This is
here?
Yes, of course you can. Please.
Yeah. So very interesting case. I think it's question oblique comment. So what my experience is that the phenotype you showed in the second albinism. So in my experience, I've seen the same type of phenotype in all 3 X-linked diseases. So this one, so even albinism, X-linked albinism, and RP as well as choroideremia, I've seen the similar kind of phenotype in all 3 types, and not different phenotypes like you have shown.
Yeah, so I think you're right, there's a bit of overlap, and sometimes I find choroideremia is a bit tricky to distinguish from ocular albinism, but usually the carrier state, but usually I find it's more messy in choroideremia. Whereas in ocular albinism carriers, it's that regular, those lines in the peripheral fundus. So, but you're right. Sometimes it can be a bit confusing. So far, I've always got it right, but you're right. Sometimes it can be confusing. And then the tapetal reflex in RP, X-linked RP, yeah, sometimes that can be a little bit challenging. You don't always see it. And sometimes it's maybe you're seeing the son and you know what they have. So like, they have RP, so it's not going to be ocular albinism, not going to be choroideremia. And then you look at the mum, you see this, and say, okay, she's got the carrier phenotype. Now we know what the gene is. But I agree, there is some overlap and it can be challenging.
And I've seen what my personal experience is when you have a more dramatic picture like you have shown in choroideremia, that is the time when even the carriers start to have some symptoms.
Yes. Yeah, I think that's right. So this patient that we saw with the choroideremia carrier, she was having some symptoms, although her ERGs were still in the normal range, but absolutely right. She did have some symptoms. Yeah.
Thank you.
Thanks. Great. And then, so this is another case, and some of these will be a bit convoluted and quite rare, but they sort of illustrate some principles that you can transfer to other IRDs. And hopefully if we get through them all, I've got then some spot diagnoses at the end, but let's see how we go. So this was a 52-year-old man who for maybe the last 10 years or so, his central vision had been reduced. He prefers dim lighting conditions. So as soon as we feel we see someone prefers dim light, they don't like bright light, we think, is this a cone problem? Could it be a cone dystrophy if it's something that's genetic? He's myopic. He also happened to have epilepsy. His cousin's son had a retinal condition, so there's some kind of family history there. This is his fundus appearance, the optos pseudocolor in the right eye, the left eye. I mean, he looks myopic. It could be just myopic maculopathy. But when you look at the autofluorescence, you see something very symmetrical. So, oh, this looks genetic to me, given that degree of symmetry. But what could it be? He had electrophysiology, and as we would predict from his history, the fact that he prefers dim light, his cone ERGs were much more affected than the rod ERGs. So we would call this a cone rod dystrophy if we think it's a genetic condition. And so he was diagnosed with the cone rod dystrophy. And actually, he was published, this is back in 2001, right? Like I call that prehistory, because in those days, we didn't know that many genes. And but anyway, in 2001, he was published as part of a series of patients who had mutations in this gene called GUCA1A. It's guanylate cyclase activating protein. And they published 3 families, and 2 families had this. Now we know it's a common cause of this GUCA1A dystrophy, tyrosine 99 cysteine, but he had this proline 50 leucine mutation. So that was interesting. That was published. Then, many years later, his daughter is seen, and his daughter is highly myopic. And, maybe she can be affected because GUCA1A is a dominant IRD. But when we look at her, and this is my colleague Andrew Webster, who's a very smart ophthalmologist, he saw her, and this was many years ago. We didn't even have autofluorescence then, but you can see a shiny reflex here in her color fundus photograph and her red free. It's quite prominent. So shiny reflex, we immediately think of what we just talked about, a carrier state for X-linked RP. But that's a bit weird because he was diagnosed with GUCA1A disease. So now we need to rethink, and this is the case in IRDs. We're constantly revising the diagnosis in our patients. We look at the published pedigree that was published in 2001, and we see that was the patient, and that's the daughter we're seeing now. And they said it was autosomal dominant, but when you look at that pedigree, there's still no father-to-son transmission, so X-linked inheritance is still possible. So then we look at this mutation, proline 50 leucine, that was found in this patient. And now we have this thing called the NOMAD database. We didn't have it in 2001. We have it now. We can type in any gene and any mutation and say, how common is it in the general population? And when we look at it, actually, this is prevalent in 0.1% of alleles. And you say, well, that's quite rare. Okay, but it's not rare enough for IRD rareness. In the IRD territory, it should be much rarer than that. If it's a dominant, fully penetrant retinal dystrophy, you can't have an allele frequency of 0.1%. So already this is looking suspicious. Was it really the cause? There are some other things for time I won't go into, but all the other mutations in this gene are in particular regions of the protein that affect calcium sensitivity, but this one is on its own somewhere else, and it's too common to really be a proper mutation causing IRD. So we need to rethink, the daughter makes it look like he's got an X-linked phenotype. We're now suspicious that this thing, so-called mutation that was found in him, wasn't really a disease-causing mutation. What do we do next? We screen the X-linked RP genes, and they were negative. But that's because there's a particular region of the RPGR gene which is very hard to screen. It's a very repetitive region, and you have to do that carefully and separately. So when that was done, it's exon 15 of RPGR. There you go. He's got a frame shifting mutation after codon 1030, which is normally the boundary between whether RPGR causes RP or other mutations cause a cone rod dystrophy. And so that's what he had in the end. And we published then a few years ago a kind of correction that this thing, because what was happening was other patients were being found to have this proline 50 leucine substitution in GCA1A, and they were being diagnosed with IRDs, and this was the cause, which is completely wrong because there's no evidence that this variant causes disease, because the patient who was published all those years ago, turned out to be an error, and in the end the disease in that family was due to RPGR. So it's very interesting, and it shows that we should always keep an open mind and modify our thoughts as new findings come to light. It shows how it's helpful to examine relatives. It shows that now we have online resources where we can look at the frequency of particular variants. RPGR, you might say, oh, well, who cares? You couldn't treat that one, you can't treat this one. But RPGR is currently the subject of gene therapy trials, so we want to know if our patient has it, and it makes a difference to the inheritance. And these exon 15 mutations can be missed even in whole genome sequencing, and it's important to communicate findings. We've thought it was important to publish this so that the rest of the world knows that this pro-50 leucine substitution in GCA1A is not disease-causing, and so to be aware of that. So there you go. That was an interesting case. And any comments as we go through, feel free to add. So now we have another case. I got an email, right? I get emails all the time, all over the world. What's your opinion on this case? Most of the time, I have nothing to add because they've done everything that they should do. So here's a case, and this is the email word for word. I have a case I'd appreciate an opinion on if possible. A 43-year-old female diagnosed as a choroideremia carrier over 20 years ago, and the maternal grandfather and uncle were told they have this some time ago. She struggled with progressive difficulty in night vision and dark adaptation. First of all, any comments on this? Maternal grandfather, and presumably that means maternal uncle also affected. And it's choroideremia. What do you think? Anyone seeing something a little bit fishy?
Male to male transmission.
Exactly, yeah, exactly right. And this is why seeing a family tree is helpful, because these are words, right? Words, we don't know what's going on. But if you saw a family tree, you'd see that means, because who's the father of the maternal uncle? It's the maternal grandfather. So that means there's male to male transmission, father to son. It can't be choroideremia, if that's what it means, unless you meant great uncle, but unless the person emailing me. But maternal grandfather and maternal uncle can't both be affected. If you have a male affected and their maternal uncle's affected, you might think it's X-linked. If their maternal grandfather's affected, you might think X-linked. But if they're both affected, it can't be X-linked, because that means the maternal grandfather gave it to his own son, and that's not possible. So already we think, oh, this looks more like an autosomal dominant history. So then they didn't find the choroideremia variant, but that's no surprise to us now because we know it couldn't have been X-linked anyway. But they found a variant in rhodopsin. Now, RHO, as many of us know, is a common cause of autosomal dominant IRD, but it causes RP, retinitis pigmentosa. It does not cause anything that looks like choroideremia. So there's something a bit funny. Then we look at the images. That's the color and the autofluorescence. They say, well, gosh, that doesn't look like RP at all because there's big patches of atrophy. It doesn't look very much like choroideremia, maybe a bit like a choroideremia carrier. They can be a bit variable. But if it's RP, you should have a good Robson ring there. You have, kind of radially quite symmetrical, but this is a bit all over the place. You can see why they thought it was maybe a choroideremia carrier or something that's not rhodopsin RP. And the full field ERGs were okay, which again is unusual for rhodopsin RP. They should have, very diminished rod responses. And this was the variant. this rhodopsin variant met 216 lysine. So he emailed me and something just clicked in my mind. I've seen that variant before. So I looked up in our database. Yeah, so this is what I've just said. It doesn't look like RP. So I looked in our Moorfields cohort and found we had a few families. And when we look at the families, they don't look like RP. This is a male, and that doesn't look that different from choroideremia, or it certainly doesn't look like RP. That's his son. And he's also got this kind of patchy atrophic disease. That's a different family. And again, that doesn't look like RP. It's this patchy RPE type atrophy. Another family, and again, patches of atrophy. So it's a strange choroideremia-like phenotype, little, not quite like it, but a little bit, but it's autosomal dominant and it's associated with RHO, this variant. Has it been published before? So if you look in the in the literature, there is an unusual retinal phenotype that's been associated with this gene that looks like that, but it's MET 207 lysine, which is different. Ours was MET 216 lysine. And you can see they also they have this patchy atrophy. Then it turned out that when we communicated, and this is Andrew Webster contacted them before I got that email from the colleague, and it turns out that this was a miscounting. Sometimes there can be errors in the literature. Actually, it was MET 216 lysine, and we've got a paper that's going to correct that, but it's been held up for a while, but that should be out. And so that tells us that if you see this variant in rhodopsin, MET 216 lysine, you don't get RP, you get this weird patchy atrophy. So again, importance of having a family history, excluding X-linked disease when you see father to son is really helpful, that we share data with each other. You have a large database, you can look at other families. And so I was able to tell him, no, this is the right cause. You're right to suspect, rhodopsin normally causes RP, but here this variant does give you something different. And I'm saying here, occasionally I'm able to respond with something useful to an email. Normally I've got nothing to add, but occasionally I can say, no, this is the diagnosis. And it's good for us to have in our minds that when you see patchy atrophy, what are the genes you might think of? Choroideremia, autosomal dominant, these genes can give you patchy atrophy. We talked about this variant in rhodopsin. RP65, we know it gives you LCA, but there's a rare dominant variant, not recessive, 477 codon, that gives you something that can look like choroideremia. LORD, also late onset retinal degeneration. We have some in the UK, maybe not much elsewhere. That can also give you patchy, RP atrophy. Recessive causes, these are the possible things that can give you patches of atrophy. RCBTB1 is a relatively recently described gene, but I've done spot diagnoses and got it just on the patchy atrophy. And then mid doesn't really look like that, but again, you can have patches of RP atrophy. So they're the things you might think of, but don't forget retinotoxic medications can look like that. Yes, sorry.
Dr. Omar, circle, CRKL, they also can have some
Yeah, I think that's right. A circle, you're right. We've seen different phenotypes. Often it's kind of university age and then the vision crashes, recessive. We've seen some milder ones than the ones we're used to. And you're right, sometimes you get patchy atrophy maybe with the CRKL as well. It's not quite RP. I agree. Good. So
Samara,
next
I
case.
just have a question.
Yes.
Again, the
Yes.
first case which you got a mail, was that a Spanish family by any chance? I'm just
No, not the ones. Yeah,
Okay.
but maybe there are some Spanish families who have it. But I
Yeah,
think the Moorfields one we didn't, and the one I got the email from was from elsewhere in the UK. Although
Okay,
actually, I
fine.
don't know what the nationality of that patient was. So
Okay,
maybe
fine,
they
fine.
were.
Okay, okay.
I'm not sure.
And the second question is that there are many other phenotypes which you showed from the RHO. Were they also VUS or pathogenic? The
Yeah, all
other,
those RHO phenotypes with the same mutation, MET 216 lysine. So this is definitely pathogenic, and it gives you this phenotype. So yeah, they were reported as VUSs, but now we have enough evidence to say that MET 216 lysine, we've got so many unrelated families, and they all have this weird phenotype that's not RP. Although all of our other rhodopsin mutations give you RP, this one seems to give you something different.
yeah, so because I have a couple of patients with RH1 similar mutation, the phenotype report as VUS, and I discussed this case with Professor Webster. That's when he told I have a Spanish
You're
family.
right. So I think it might be you. You've
That-
got someone at a neighboring codon.
yeah,
Yeah,
yes,
exactly
yes.
right. Maybe
Yeah,
215 or something. He told me about it,
exactly.
and they have a
Yes.
similar phenotype. Yeah. So I think one possibility is we could even add that to this series because it doesn't seem to be anywhere
I'm
near
planning to. I mean,
submission. So
Yeah, I mean, I
Yeah,
just it's
so
only a couple of months where I made to send him those complete details. I'll share those
yeah,
details with you.
that'd be
Then
great
we
because
can
it
add.
suggests that that other codon that's right
Yeah.
next to it, I think yours was 215, may well give you the same phenotype. Yeah,
Thank you so much
thanks.
for showing this
Great.
case. Yeah, interesting.
And so now we have another case. This is a 24-year-old Somali. Parents were consanguineous, as we see in some of our communities. And he was referred 7 years before that because of reduction in his central vision. And now his vision was 660, so very poor, unfortunately. This was his fundus appearance, and that's his autofluorescence. So he's got macular atrophy, but he's got something else as well. So what do you think, anyone? What's he got? Feel free to
Looks like
unmute.
angioid
Angioid
streaks.
streaks.
Yeah, exactly right. Yeah, angioid streaks. So we see the angioid streaks. What's a little bit weird about this case is that he's got atrophy in the center that's not contiguous. Yes, you can definitely get atrophy, macular atrophy with angioid streaks, but normally it's from a streak going in there. It's not normally kind of just discontiguous. So that's a little bit weird. But yeah, angioid streaks. So we're thinking,
No,
what condition?
pattern dystrophy can be associated by, I think, foveal atrophy like this is a little, but pattern
Then,
dystrophy can be there.
is this in
Yeah,
compound
but with
heterozygous with
angioid streaks, we
ABCA4?
think, yeah,
If you
well,
keep the ABCA4 aside, if you just look at the macular atrophy, could be a compound heterozygous ABCA4, not the
absolutely
disease.
right. But ABC4, to our knowledge, never gives you angioid streaks.
No, no, no.
And
If you
so
keep the angio
for that,
streaks apart, just look at the macula, and it could be looks like very typical of an ABCA4,
yeah, you're
not the
absolutely right.
recessive one, the compound heterozygous one. Yes.
Yes. And or even homozygous for a particular codon mutation that we'll see. But anyway, first he's got
J16.
the
Yes.
angioid streak. So we've thought about, and this is my predecessors thought about ABCC6, pseudoxanthoma elasticum. That's what's associated with angioid streaks. This is the thing we learn, Pepsi, right? But what we should do is cross off Ehlers-Danlos, because if you look, we've got so many PXC patients and they have angioid streaks. Ehlers-Danlos, there's only one case report in the literature. Everyone quotes the same case report. Green et al. In like the 70s or something, they had two siblings with Ehlers-Danlos and they had angioid streaks. But I don't think it's really been seen since. I mean, maybe it could be very rarely. And there was this paper published a while ago that looked at a big cohort of Ehlers-Danlos, and they said they couldn't find any angioid streaks. And that's why they suggested for Pepsi, I know it ruins it because E is now not Ehlers-Danlos, E could be elasticum, pseudoxanthoma elasticum, so we can still say Pepsi, don't worry. And then we looked in our big cohort at Moorfields in response, and again, hardly anyone out of 227 patients with Ehlers-Danlos had angioid streaks, like one patient possible and or two. So it's not really common in Ehlers-Danlos. Maybe it's seen rarely, but PXC is the big association. So he had ABCC6 screened and he had a homozygous duplication in ABCC6. So then this got published back in 2012, right? Maybe not prehistory, history, as angioid streaks giving you severe macular dysfunction. So this odd phenotype where you have macular atrophy. And so Dr. Poorna correctly said, hold on, let's think about other things as well. And that was what Andrew Webster thought as well. When he saw this patient, he thought, well, look, the commonest genetic cause of macular atrophy is ABCA4. We know that a particular codon is 1961, which gives you either heterozygously or homozygously, either heterozygously with whatever other pathogenic allele on the other allele, or homozygously, you just get kind of macular atrophy. And we know it's quite common in our Somali patients. And we don't like our patient to have two different IRDs, rare conditions, but he is from consanguineous pedigree, so it's not impossible. And indeed, he did screen that. And we found that he's got ABCA4 as well. So again, we published a correction to say that, look, this patient had ABC6 and ABC4, and always have an open mind that your patient might have more than one thing, and see does the phenotype fit the genotype. Good. So it's super, super interesting, isn't it? Right. So now we'll go to another
The only
case.
good thing is that he'll not get CNVM in the macular area.
Yes, that's right. Yes, that's right. Yes, absolutely. So now we have another case. This was a 50-year-old who was myopic since childhood, And then the last several years, vision had got more blurred, and it's a bit similar to a patient we've already seen. This was the vision, age 45, so quite impaired, and we can see that there's some macular atrophy and also some degeneration in the periphery. They're also high myopes. Could that just be myopic? But certainly the center isn't, you can't just attribute that to myopia. That's looking very symmetrical and, macular dystrophy or cone dystrophy like. So we already seen a patient like this who was highly myopic with a cone or cone rod dystrophy. So it's something to think about. And then we see his OCT, and he's got, outer retinal atrophy. He's got the dome shape you get in many myopic patients. And the other thing is, in the periphery, he had a little bit of a sheen. And that sheen, in the context, you can get it with X-linked retinoschisis, but this isn't X-linked retinoschisis. You can get it with RPGR associated cone rod dystrophy. And you can also get it with another thing called TTLL5, is an autosomal recessive condition that can look a bit like this, also associated with myopia. So those were my two differentials. So if we look at my letter, okay, then he had cone rod dystrophy on. I'm just going back to our review. If your mutation in RPGR is after about codon 1030, it's not quite codon 10. Edstone always says 1030, but actually it could be even earlier. You get like a cone or cone rod dystrophy. If your mutation is earlier than that, you get RP. So I said in my letter, this would be consistent with a later onset cone dystrophy. Possible genes include RPGR. And if it's RPGR, it'll be a late mutation, maybe after codon 1030. Or TTLL5 is the other gene. And in fact, TTLL5, that protein interacts with the end bit of RPGR. So that's probably why those both diseases give you the same phenotype. And we organized genetic testing, and we got an inconclusive report. But what they did find was a variant in RPGR. They called it VUS, uncertain significance, but it's where we predicted. It's after codon 1030, and it's absent from the NOMAD database, so it's very rare, and it's predicted to truncate the final exon. So for me, although they report as a VUS, for me, this is the cause, because they'd sequenced all his genes. So TTLL5 didn't come up. There were only two genes we were thinking of, and the one gene, and even the place in the gene that I predicted, it was. So we were able to say, this is your genetic diagnosis. And again, this has ramifications for counseling, the inheritance. You might have females of childbearing age in his family who might want to know about this. There are trials for X-linked RP if one of those female sisters or something has a child. So these are things that we might want to know about. And again, it's the phenotype used to predict the gene. Yes.
Professor Omar, what was the ERG features in that one? The one which
so he had cone rod dystrophy on ERG, so cone dysfunction. Okay. But we have seen even late mutations in RPGR just give you macular dysfunction, and the cones are relatively normal and the rods are normal. So you can even get it that mild.
Okay, fine. Were there any preserved signals on multifocal ERG, or was it?
I can't remember whether he had a multifocal ERG, but if there was, there probably would have been reduced signals in the center. So he had undetectable pattern ERGs, and that's what you'd expect with that macular atrophy. Also, the high myopia, often you've got a funny shape of the macula, you get the reduced pattern ERG as well.
Yeah, pattern is obviously, it is, I was interested in multifocal, fine. Good to know. Exon 10, right? Okay, fine. Interesting.
Yeah, exon 15, or 15, you'll know that's where the mutation is, yes.
Dr. Omar, can I ask you one question? So,
yes, of course.
While in such kind of patient, the last one you just presented, while you are getting full field ERG, that is understandable. But what is the use of pattern ERG in such a case?
Yeah, that's a good question. So, to me, actually, we could have just gone for the genetic testing, but your full field ERGs will also guide you a little bit. The pattern ERG, I think they just do it because it's their standard at more fields. They do it. Everyone who gets full field ERG, they do a pattern ERG as well. But you're right. You already know that it's going to be down because he's lost his outer retina at the macula. You already know that when you have these funny shapes, even when the outer retina is normal, often the pattern ERG is down because I think it's not falling, all of it in focus on the whole of the macula, and that could be a reason why the pattern ERG is down as well.
Yeah, and
So
I
yeah,
think
maybe
Do
it
the
doesn't add
similar. We
much.
do it as a package along with if fulfilled. We
Yes.
always combine with the pattern and the multifocal. Sometimes you do get funny results, unexpected things. So it's always better to do everything. The
Yeah.
McDonald's totally. I mean, lost. I mean, we get signals, vice versa.
Yeah. So this is another case now, a 42-year-old who'd been diagnosed many years ago with a retinal vasculitis, and they'd even talked about sarcoidosis, and she'd had some flashing lights, otherwise no particular problems. She was then seen by my uveitis colleagues, and they correctly said, "Oh, this is looking a bit symmetrical. Let's just see what what I think." So I had a look, and vision is excellent in both eyes. That's the fundus, so some pigmentation, not much to see. We want to see the autofluorescence. Okay, the OCT is looking good, but when you go to the edges, there is some outer retinal loss. But centrally, it's very good. And then we see this pattern of degeneration. So normally for RP, you get a Robson ring. So this doesn't look very typical, but to me, it was symmetrical enough for us to think, well, let's consider genetic testing here. And I had one particular gene in mind. Any ideas what gene? So, I mean, she's got no family members affected. So if this is RP, a very mild RP, we think it's autosomal recessive. She didn't have congenital night blindness, so we don't think it's one of the phototransduction genes. So our commonest genes are like USH2A, EYS, a few others, like many others as well. But particularly EYS, we've often seen this funny shape where you have more sparing superiorly than inferiorly. So it's almost like looking like a shield. Not always, not at all always, and there's a whole spectrum of severities, but it's a gene we think about. So this was my letter. I said, it's not wholly typical of retinitis pigmentosa, but some features are suggestive, particularly of a pattern sometimes seen with EYS-associated RP. But it's also possible it's an inflammatory retinopathy as previously suggested. So I wasn't very sure, but then the result came back positive, 2 variants in EYS. So as soon as we got that, the very thing we predicted, then I said, okay, this is what it is. So you don't need why did she get diagnosed with the vasculitis? Probably because when you do a fluorescein in these patients with retinal degenerations, often you see non-specific leakage. So someone looks at it and says, oh, they got a vasculitis and, she's got some symptoms. So we'll call it that. So okay, there's no treatment, unfortunately, for EYS, but she's got so much preserved retina at this age, I think, hopefully, she'll never have any problem with her central vision, or not for many, many years, hopefully never, because, we know it progresses very slowly. So, whereas a vasculitis can come and go and might need treatment. So in a sense, yeah, I mean, it's not good to have a genetic dystrophy, but maybe it's good news in that she's got very healthy central retina. So I'd hope that her vision isn't immediately under threat or not for many years, if at
I
all.
missed the age. What was the
Dr.
age
Omar?
of this patient?
Fifth, good question. I think 42. Yeah. So
Would you
that
want to
might.
42.
would you want to consider
Yeah.
autoimmune retinopathy in this?
Yeah, absolutely. So it was something that you'd consider as well. And sometimes there's this overlap, which is why we really want to get a genetic cause if it is genetic. And the fact that we then got, so you're absolutely right, autoimmune retinopathy could look like this. It can be very variable.
You
But
also
given
mentioned
that,
about the flashes that the patient,
yeah, but
that's
some
something
of
very
our mild,
typical.
yeah, you're absolutely right. But also our RP patients, sometimes they get flashes too. We see that not infrequently as well. But you're right. Sometimes we are a bit confused, and there's this, overlap between autoimmune retinopathy and RP, and that's one of the reasons we do genetic testing is just, because the uveitis guys think it could be autoimmune. They're not sure. If we don't get a genetic cause, that might make it even more likely autoimmune. Although there's 40% of our patients who are genetic, we still can't find the gene, so it doesn't make it certain. But if we have a definite genetic cause, then at least we can spare this whole autoimmune business and trying to immune suppress them and all of that when we know actually there's a genetic cause. So we do find that helpful. There's another
42
case.
with
Yes.
the EYS. I mean, it's a very mild phenotype. I mean, to me,
Yeah,
for
very
my
mild.
cohort,
And one thing
well,
I completely agree. And one thing we're realizing now is that it's much more variable than we used to think. We used to think we know, this gene gives you this gene, and we're just getting like even the LCA genes, we're seeing like these later onset presentations, mild RP, and we get, bewildered that it turns out to be a gene that usually associated with LCA, like CRB1, for example. So this patient is just a quick one who had, she was 62, night vision problems from her 40s, and she's got clear RP. no family members affected. So, and her night vision problems, she's very clear. Before her 40s, she could go to a cinema, no problems with her night vision. So that immediately takes out those recessive phototransduction genes, PD6A, B, CNGA1, CNGB1. It's not going to be any of those because they have night vision problems right from the start. So now we're thinking, are other causes USH2A, EYS, other things? But I just thought, oh, look at this pattern. The Robson ring here again is showing that slight asymmetry, not quite like the other person, but slight asymmetry. I said to the fellow, I wonder whether she's got EYS. This was just a couple of weeks ago. Then she'd had testing, but it was in a different department, so I had to email them. And then the email came back after she went, and she had 2 variants in EYS. So unfortunately, the fellow had gone home, so I couldn't show her. Look, it's exactly what I said. But anyway, I was able to then contact the patient. Yes, it is that. And so, you know, as you said, this is maybe more typical. In fact, we often see severer than this. Someone 62 with EYS, that's still very mild because we've seen much worse than that. But there is a spectrum with many of these genes.
It's very mild, very mild. I mean, Indian cohort of EYS, I mean, by that 40, 50,
Our
the
cohort too. Yeah,
the
for us
Robson ring
too,
will
that
be
most,
within the arcades. I mean, the first time I'm
yeah.
seeing something outside the arcade, I mean, just going
And
to
most of our EYS patients the same. Yeah. So these are very unusual,
Yeah.
but we're getting to like familiar with those unusual ones as well. This was a 64-year-old, 36-year-old, not 64, referred from the uveitis clinic. And they had presented with some blurring of vision. And he was found to have some CMO, so started on Acular and Maxidex. He was then worked up for uveitic causes. He had this positive P-ANCA, no one knew what to do with. He went to rheumatology. They didn't think it was significant. That's his OCTs. And you can see, and they saw a few cells as well in the anterior chamber. And you see the OCT, there's something, as well as the edema, there's some kind of weird outer retinal hyperreflectivity, which is a little bit strange. And he was started on prednisolone. This is in the external uveitis department because they thought it was uveitic. And he was given a weaning regime, and it didn't really change much. That was his fundus appearance and autofluorescence. I think this is a video. Let's see if it plays. Yeah, so this is OCT. Very weird outer retinal columnar abnormalities. Has anyone got any thoughts what it might be? So
I think you
one
recently
thing.
published it. Yeah, I saw that.
Absolutely right. You've got it exactly right. Yes, we have. So, and this patient wasn't even in that series, but exactly right. So this was presented by our Professor Bird teaching Monday evenings. We have, I can't remember if I've told you about that, but we have that Monday evenings UK time. It's on Zoom. You're all invited. If you want to join, we'll add you to the mailing list. And 5:30 for us, I guess, is maybe a bit late for you, like 10, 11 p.m. or something. But you're very welcome to join. So it was presented there, and Peter Charbel Issa from Oxford said, "Oh, I think this is CRB1," and Adnan Tufail from Moorfield said, "Oh, I agree." And then and then it's fluorescein. Yeah, I'll go quickly because we have other cases. But it made me then remember that, oh yes, I have seen this in CRB1. Indeed, when we published in 2016 the maculopathy, I told my co-author, I think there's something funny about the outer retina, but he kind of dismissed it, so I'd ignored it since then. But clearly there is something. So I said, so then this patient got referred to me as a remote consultation. They didn't even have to set foot in Moorfields. I said, I've seen your images. I think it could be CRB1 maculopathy. If it is, then we always find that one of the mutations is this codon 167 to 169 in-frame deletion. So let's do it, and let's try and get the answer quickly, because then if we know it's CRB1, then at least they can stop all these steroids you're on that, aren't going to do you any good and aren't really going to help in this situation. And we got the result, and it's exactly, one of his alleles was exactly what we predicted, 167 to 169 deletion, and he had another pathogenic variant on the other allele, so we knew it was CRB1 retinopathy. And this is the paper we published back in 2018. Cameron Khan had put these patients together and found that all of these CRB1 maculopathies, so CRB1, usually it's an LCA gene, or severe early onset retinal dystrophy. We found now a cohort of patients, most of them who have this mild hypomorphic allele, they just get a maculopathy. Very interesting. And then you're absolutely right. We've just published these outer retinal columnar abnormalities as a sign of CRB1 maculopathy. So sometimes it guides you to that diagnosis. So the same gene we're realizing can give you very different phenotypes, and confirming the genetic diagnosis, yes, it might not improve the patient's vision, but it could save them from undergoing unnecessary treatment. I have to say another thing is I thought in these patients, eventually they get macular atrophy. That's not the case. We've had a few that have stayed with good vision, and this patient with no treatment has now his cysts have resolved and his vision has gotten better. So that's really, we can give patients, maybe not so much bad news. I used to say these patients, oh, maybe in some years the vision might go down because all the other CRB1 maculopathies had done that. But now we've got a few patients who are maintaining good vision. So it's not necessarily inevitable.
So any of your CRB1 cohort had peripheral angiomas?
Yeah, we've got a few with this Coates-like vasculopathy, whether you call it vasoproliferative tumor, something like that. Yeah, and they can be quite hard to treat.
Yeah.
And even some of our other IRDs, like USH2A, things that aren't usually associated with the Coates-like vasculopathy, it's normally CRB1, but we've had some of them have this Coates-like vasculopathy as well, and it's very hard to treat in our experience.
Yeah, my cohort, not exactly like Coates, but just an isolated angioma which just responds to one cryo we have seen like that. I mean, it's not troubling much to manage. I mean, luckily it's not completely Coates like, just single isolated VPT like lesion angioma.
Right. Interesting. Yes. Okay, so I thought I'd finish with some quick OCT spot diagnoses. And we already saw a CRB1 spot diagnosis. Normally with CRB1 retinopathy, the macula's thickened, but in this other thing, you can get just those outer retinal columnar abnormalities. What do you think this is? Any comments? You just saw that OCT. There's a couple of features here that tell you what the patient has. I can give you some more history. They had some hearing loss. They were referred to the retinal clinic because they had, and their vision was down, and they've got this funny OCT. Any thoughts? This is the other eye. So there's two things of interest here. So firstly, everyone's attention is drawn to this weird splitting of the outer plexiform layer. So that's very pathognomonic, to be honest. But the other thing that people don't see is he's lost his nerve fiber layer and ganglion cell layer, which I'm always telling our retinal fellows, don't you ever dare miss that because it's important. Sometimes we have patients and they've got a few cysts or a vitelliform lesion. Everyone focuses on that. They don't see they've lost the nerve fiber layer because usually the nasal retina should be thicker than the temporal retina. Imagine if you didn't see this image on the left, you just saw the OCT, you wouldn't tell which eye is it. Is it the right eye or the left eye? Because you think that's nerve fiber layer. It isn't, because when you count, that's in a nuclear layer, that's in a plexiform, there's no ganglion cell layer and no nerve fiber layer. So this guy's got bilateral optic atrophy, and he's got hearing loss, and he's got this pathognomonic OCT sign. We only see this in dominant Wolfram syndrome. So WFS1, which gives you recessive Wolfram, DIDMOA, diabetes insipidus, diabetes mellitus, optic atrophy, deafness. You can get a dominant changes in that gene that are not as bad as the recessive Wolfram syndrome, but they give you optic atrophy, deafness, and they give you this only dominant, not recessive Wolfram. You get this very interesting change in the OCT. So if you see that, then you can think about Wolfram. And actually, this patient hasn't even had genetic testing yet, but they'll have it. This is Melina, my colleague, who diagnosed this, and I'd be very surprised if they don't turn out to have a mutation in WFS1. This is another spot diagnosis. So these are some outer retinal abnormalities on OCT. And I did show this in my last lecture, but they're not like the CRB1 ones. The CRB1 was continuous with the ellipsoid zone. It was as if there was a defect in the ellipsoid zone, and then you had this column going up. These things are at the level of the ELM.
Danon.
So, yeah, brilliant. Excellent. Danon disease. And usually it's female carriers who show this. But very, rarely a male who might be a mosaic could show this. So the males with Danon disease usually have much more retinal atrophy. But this, as you might remember, was a patient I saw in this very hospital, in St. Thomas Hospital at the moment. I saw here, someone just showed me the image. I said, I've only seen this before in Danon disease, before I knew anything else about the patient. I said, is his heart all right? He said, yes, he's under the cardiologist. He's been referred to eye casualty because an optician saw something and he had this funny pigmentary retinopathy. I said, this has got to be Danon disease. And I told the cardiologist later, after clinic, I went up to just check they got my letter. They hadn't, so I talked to them, and they said, oh, we thought he had a cardiac vasculitis. And then the next day, Saturday, they emailed me back. They said, we looked at his cardiac imaging again. We think you're right. It's Danon disease. There are only 3 centers in the country that deal with it. He got sent there. He had a cardiac transplant, and he's still alive. 2 years later, I just saw him a couple of weeks ago. He's doing great. He's very well. He's even got taller. He was 16, and he's had like a growth spurt. And so, here's where the ophthalmologist can help the general physician in getting the right treatment. They were going to do an endomyocardial biopsy, but they cancelled it because we had the diagnosis. Obviously, they did the genetic confirmation, and he had LAMP2 mutations. Okay, this is another patient, congenital night blindness, not too bad vision. There's some reason I've done a wide field OCT. What do you think they have? And this is the other eye. They have congenital night blindness, and they had pathognomonic ERGs. And I was able to do just one protocol with my Retival and see this big S-cone response. So this is enhanced S-cone syndrome, NR2E3, autosomal recessive. It could also be NRL. Often you have macular schisis, but not always. And they get this nummular pigmentation. That's the autofluorescence. I haven't got the color images. And sometimes the mild ones just have this banana-shaped abnormal autofluorescence. And the interesting thing on OCT that's been described is that when you OCT, normally our OCT doesn't go that far out, but when you OCT over the area of degeneration in these patients, all of the layers are disrupted. Again, I can't say 100% of the time, but often, which is different from, say, our RP patients. When you OCT over the area of retinal degeneration, the inner layers are okay. But in this patient, where you get the area of degeneration, even the inner layers don't look normal at all. And that's a clue, again, to NR2E3 retinopathy, and that's what this patient had. Here's one last OCT spot diagnosis. Imagine someone has this in both eyes. You think their vision should be terrible, but they're like 6'9", and it's been stable all throughout their life. What do you think? Maybe you don't see much of it there, to be honest. It depends where you are. So this is exactly right. Exactly. North Carolina macular dystrophy. So it can look like this. Actually, unusually, her other eye had a normal OCT. Normally, they're symmetrical in both eyes, but you can have different, even in the same family, you can have this so-called macular coloboma. You can get different kind of disruption at the macula, something that gets diagnosed with bilateral toxoscars, or you can have just fine drusen-like deposits. But as soon as you've seen this, I thought this is North Carolina, and there are 2 genetic loci that can give you North Carolina. There's a 5p duplication or 6q variance, and she had the 6q variant. So we were able to tell her that's what it was, completely stable. And always their vision is better than you'd expect. Like you see someone with that, you think, oh, that'll be 660 or something vision. She was 6'9", amazing. It's a developmental thing, and then it's stable throughout life. This is a autofluorescence spot diagnosis, and I showed it last time, and so you might get it. So this patient had paracentral vision loss, then central vision loss. They had a dominant family history. Any thoughts? They have this posterior polar degeneration, then they have a nasal degeneration that's discontiguous. So that's quite unusual to have degeneration in 2 different parts that aren't even connected to each other. So I've only seen this really in and he's got some degeneration down here that you can barely notice because he's got the eyelashes in the way. I've only seen this pattern really in CRX-associated disease. CRX can just give you a maculopathy. It can give you a severe retinal degeneration. It can give you a cone rod dystrophy. It can give you bullseye maculopathy. But some patients have this, and about 10% of our patients, of our cohort, CRX patients, have this. And we published this very recently, that whenever you see this kind of discontiguous nasal degeneration simultaneous with the macular degeneration, think CRX. I mean, maybe some other genes can do it, but I almost only have seen this in CRX. And there's some other cases where we, weren't sure, and we found a deletion in CRX based on looking for it because of the phenotype. And we published that the very day that I gave you the lecture last time. Wednesday, December the 4th. I really wanted to show you, but it didn't get published until after I gave you the talk. Anyway, so quite recently published. So that's the end. Sorry, I've gone a bit over time. Do feel free to email me anytime. We can add you to our mailing list for the Zoom meetings that we have on a Monday evening. Very happy to discuss things, and sorry to go over time. And we've only covered just, the tip of the iceberg in terms of all of the interesting cases that we see.
Very interesting always. I think we are all bedazzled and we are awestruck as to what all can happen in the field of genetics. Regarding one last case, the North Carolina, which is not very common in our part of country, but we do see lots of macular coloboma, so how big these colobomas can get?
They can get bigger, and the clue is usually and their vision could be worse. Doesn't need to be 6/9. It could be 6/36, something like that. But usually it's been stable throughout life. So we do see many patients where they have a lot of excavation, but they've got a terrible vision and a progressive disease. So even in ABCA4, not like that, but we can see some excavation. The two diseases that are quite severe that often give you this macular coloboma are so-called coloboma. That's not a real coloboma. It's not failure of the optic fissure, but is RDH12 and NMNAT1. Those two genes, we often see a big excavation with it early on. So those are the genes we think of. But sometimes if you have someone who's been diagnosed with bilateral toxoscars, you should think, could this have been North Carolina? There's something else that I've never seen, but Arif Khan, who's based in the Middle East, he's seen some patients with Claudin 19 mutations. It's a recessive genetic condition that normally gives you a renal problem. But he's seen a particular variant that gives you just bilateral macular, what looks like toxoscars, and it doesn't give you any syndromic changes, I think. And again, they get misdiagnosed as toxoscars. Looks like North Carolina, but it's Claudin 19. But I don't think we've ever seen it, and maybe it's just something in the Middle East and maybe nowhere else. I don't know.
Thank you.
We need to sequence these patients who present, because we have a lot of, as Vinod sir rightly mentioned, these kind of phenotypes presenting both unilaterally, bilaterally, varying degree of excavation, one eye excavation, other eye just a macular atrophy, no excavation.
Yeah, so usually the North Carolina, they're symmetrical. We only had 2 patients that were asymmetric, but they still had phenotypes in both eyes. Just the funny thing about this patient was in her other eye, she just had the fine drusen-like deposits. OCT looked normal. You could just see on autofluorescence it was abnormal. So she looked like a combination of 2 North Carolina phenotypes. Normally a patient is either got one or the other the same in both eyes. So she was unusual that way. And it can be hard to sequence because it's a intergenic region that's quite far from any gene. And even in our NHS National Health Service lab, they still can't do North Carolina. But at that time, we happened to have a PhD student who was doing her PhD on North Carolina. So she did it for us, and we were able to genetically confirm that patient.
I think thanks to Dr. for your fabulous presentation. And I think most of us have, at least I have been busy taking notes, and so have not been really discussing, but amazing. And definitely, I think, I don't know whether the spectrum is different or you have brought in some very rare cases which we don't see very often in our part of the country, but maybe the disease spectrum is also different. So it's always a pleasure to hear you and learn from you. Thank you.
Thanks, and it's a pleasure discussing with you as well. Thank you very much for the invitation.
Dr. Mayank, any comments? Actually, Dr. Omar, every time we listen to you, we learn something new.
Yeah, exactly that. So every time it's just a treat to listen to all the cases that you discuss. I was curious that would you have any hypothesis for the variable phenotypes that we see? For example, the CRB1 gene case that we saw.
Yeah, it's a really interesting question, and it's probably different genotypes are doing different things. So now it's not enough, as I say to my fellows, that if you tell me the gene, that's schoolboy level. Now I want to know the variant in the gene. Is it? Because I'm joking, obviously, but I think different variants, like we're recognizing that that CRB1 167 to 169 deletion, always you just get a maculopathy. But why? It's a really important question. So is it because it's hypomorphic in-frame deletion? It just doesn't mess up the protein so much. We also know CRB1 is expressed in photoreceptors and Muller cells. So maybe the maculopathy is some Muller cellopathy. I was thinking about this a while ago because MacTel, completely different disease, not CRB1, is also, there's some evidence suggesting that MacTel is to do with Muller cells. And Prof Bird talks about this a lot. And I remember having a patient who I can't remember which way around. They'd been diagnosed with MacTel and it turned out to be CRB1. So clearly there's a bit of overlap. She must have had some cysts and they thought it was MacTel. So it may be this Muller cell, it's the Muller cell expression of the gene or the Muller cell isoform that gets messed up in this disease, and it's the photoreceptors in the other disease. I don't know, but these are all possible hypotheses. And then the other thing is sometimes in other genetic conditions, we have the very same variant looking different in different people, and then we don't know what's going on there. It must be your other genetic modifiers, other genes in the same pathway, some environmental thing. And I think that's the next frontier now. Yeah, we've got all these genes, but now we know what's all the other modification going on. And if we can work that out, that might also be a target for treatment. If we can work out what's making one person mild, another person severe, maybe we can make the severe guy mild if we can work out those modifiers. But yeah, very early days yet.
One question to Mike. I think these days we are seeing a lot of these patients with variation. There's a lot of interest on gene independent factors in this phenotypic expression, so which we often tend to ignore. So that many things, and we have an ongoing experiment where doing something in the mice. Hopefully, we should be able to publish that the gene independent factors. So that's a very interesting thing we need to look into, because that too, especially in Indian cohort, of course, it must be true in their cohort. So very much variable. Same family, same gene, same mutation. So different phenotypes. So I mean, if the mutation is different, I can understand gene being same. So I mean, there must be something like this, Professor Mahroo rightly mentioned.
Do we have any other comment? I don't see any questions in chat. So
very interesting lecture, Professor Mahroo. Very interesting.
There's some cases where you do not find your genetic mutation or variant in the exome testing. So how often would you straight away go for a whole genome? Or since you already have a diagnosis in your mind, would you rather just test for that particular variant alone?
You're right. It really depends what your kind of local infrastructure is like. I think if you are trying to do everything rationally, you probably would, sometimes you've got excellent family history. They got SCISIS. It's only RS1. Why would you test the whole genome? Or dominant drusen, EFEMP1, particular variant that gives you that, for example. So sometimes it might make sense, but the way testing is now, that often it costs the same sometimes to test a whole load of genes as it does to test one gene. You have massively parallel sequencing.
As a second step, first, of course, you would do a exome sequencing, a whole exome sequencing.
Yeah,
but
I mean, what? Yeah, I think so. You would, but for us here, I was telling you what we would do logically, but actually here everyone goes to whole genome because the UK has taken a decision that every inherited retinal disease they'll do whole genome sequencing, which in some ways you think, oh, that's mad, but maybe they feel let's just do one test for everyone, then we won't miss anything. That could be there, and then also the data is there for the future. And maybe the other reason is that you have that big data bank of genomed individuals that you can use as a reference for other conditions. So how common is this? Oh, well, let's look in this whole data bank that we have of whole genomes. So that may be the reason that the UK, certainly England, I don't know if it's all of the UK, has moved to whole genome sequencing nationally funded. So it was a big endeavor, but I think it's great. There's a big backlog backlog. So it takes us now a year to get a result, which is quite a long time. So the ones where we think it's going to make a difference, we send to a lab in the US so that we get a quicker result within a couple of months. And John Chang there at the Molecular Vision Laboratory, he does 1,000 genes and gives us the result in 6 weeks. So it depends on your situation. You're absolutely right. You could start with exome, and if you don't get it, then you go to whole genome. Actually, what we do here, just from the setup, is we go to whole genome, unless we want a very quick result. And then at Moorfields, we have this a connection with this lab in Oregon, and they do 1,000 genes very quickly and give us loads of VUSs, and then we're confused, but then we have to work through them.
Okay. Thank you. Here, I don't think we are still anywhere close to a whole genome sequencing, but then yes.
Hello, everyone.
And as you say, whole exome, but then you've got, ABCA4 has many deep intronic variants that are now well known, and so would you do the whole exome, or it looks like ABCA4 just do that and the introns or something? Again, depends
something like
what you
that.
have
That's what
access
we
to.
do here. We do a whole exome, and then if you don't get what you really want, and if you have something in mind, we just go dig for that, rather than, because the cost of the whole genome again would be very high for the patient to bear that.
Yes. Yeah. Sorry, I interrupted someone. I think someone else
Yes.
was asking something. Sorry about that. I don't know who it was.
Manu Sharma. Manu wanted to ask something.
Yes. Yes, Dr. Manu.
Hey, hello everyone. I am Dr. Manu Sharma, and I'm doing MCH at PGI Chandigarh. So I'm doing thesis in road-con dystrophy. So I was just looking at my images, what my thesis patient have. I have eyes gene positive 7 patients. They all have different phenotype. But sir has told that big autofluorescence ring was seen. Only one patient of mine had that ring. In one patient, I have diffuse patches of choroidal atrophy. Sorry, the retinal atrophy, like nummular appearance, which is typically described in one of the photo, the peripheral atrophic patches. And in one patient, we find in 3 patients, I have granular appearance, the typical rod-cone dystrophy, granular appearance. With in the center, there is Robson-Holder ring.
Yeah,
So
and
I
I agree that you can get variable phenotypes. That's very interesting, and even when you have the ring, I find sometimes, not always, but in some of the EYS patients, it's still not quite a circle. It's kind of got that more sparing superiorly than inferiorly, so that can sometimes be a clue to EYS. But you're right, we do see different, and the patients I've shown, I can't say they're typical of EYS, but it's something, it's instructive because why are you getting genetic testing? Well, that patient was diagnosed with a
there are
vasculitis and was going to
different
be
patterns we are
immunosuppressed.
seeing in all the genes. We are seeing different patterns. All
Yes,
the patients
yes.
have different pattern. In only one patient, I found that big ring going out of the arcades.
Right. But even with your smaller rings within the arcades, do you find
Yes,
that it's
sir.
a bit more spared superiorly than inferiorly, or no?
No, sir. In 2 patients, I have small ring in the center, and in one
Right,
patient, it is the size of 2D diameter, and in one
right.
patient, it is going up to the arcades.
Right. Interesting.
And in 3 patients, there is granular pattern, what is typically described in Sada's article. And
Right.
in one patient, we found the nummular pattern, the nummular
Right.
patches of atrophy in the center. The periphery is fine.
Most
Yeah,
of the rings, I
interesting.
understand what you're trying
We'll
to
look.
ask. I mean, the rings are circular in most of you in our cohort. You wanted
Yes,
to
sir.
know the asymmetry of the ring, right? Slightly towards upper side. That's not so
Yes.
in the cohort what we are
Yes,
seeing.
yes.
Maybe that's what Dr. Manu is trying to convey. The rings
Yeah.
are not bigger within the arcades, but they are circular, not asymmetric or not
I'm just
square.
analyzing the figures nowadays. We'll hope some other inputs from sir in the next meetings. Thank you.
Thanks.
Thank you, sir. And actually, we learned a lot. I think we'll get another class from you. Basically, this is so interesting, and we in India actually we are much behind what you are doing. So we actually want to learn, and I take this opportunity to thank our panelists, Dr. Parveen Sen ma'am, Dr. Vinod sir, Dr. Poorna Chandra, Dr. Mayank, and Dr. Simar. And I thank all the audience for being here. And I think we learned something new today. Thank you, Dr. Omar. We are privileged to have you. And we'll try to contact you again to have similar classes. Thank you.
Thanks very much. Yeah, I'd be happy to. Thanks.
Thank you. Bye-bye.
Thanks, everyone. Good night.
Good night.
Thank you so much.